how do you treat hypertension? So see, we have studied in pharmacology. I mean, those who have done second year pharmacology classification, antihypertensives, you have many list of classification. So you can consider here ABCD. A for angiotensin receptor blockers. We have AC inhibitors other side, but here we take it as ARBs, angiotensin receptor blockers. B for beta blockers, C for calcium channel blockers, and D for diuretics. Diuretics, we have thiazide diuretics here, thiazide diuretics. So ABCD. Now A for angiotensin receptor blockers, one of the main thing used. B, beta blocker is not used now as a first line of drug. This is the first line what I am saying, ABCD. The beta blocker is not used as first line. Beta blocker is used when we have hypertension associated with the coronary artery disease. I'll come to that again. So A, B, C, D. In that, A, angiotensin receptor blocker, B, beta blocker, C, calcium channel blocker, and D for diuretic. So B is not used nowadays. So first line of drug you can say A, angiotensin receptor blocker, C, calcium channel blocker, and D, diuretics. These three are the first line of drug or the front line of drugs you can say for the management of hypertension. So first when the patient when he comes, you can say start with A plus C, angiotensin receptor blockers. For example, Fimsartan is a classic example. You can give Fimsartan. So in our places, Telmisartan is a common thing. We get Telmisartan, Losartan and all. Fimsartan is there. That is the best thing to give, 60 mg to 120 mg night time. Okay, that is the first thing. A, angiotensin receptor blocker, Fimsartan. If Telmisartan 40 mg is available in our place commonly, that also can be given if Fimsartan is not available. 40 mg in bedtime. Second is C. C, you can give calcium channel blocker. What we see in our areas, nifedipine and cilnidipine are we giving. So we can have if we have a drug of benedipine, which is 4 mg and 8 mg tablets, BD or OD. BD is like, so benedipine, if you have benedipine, that is the first you can have a preference. If not benedipine, you can give cilnidipine. Cilnidipine you have 10 mg, what is available in our any areas now. Amlodipine is not at all given now. It's more commonly pedal edema is the main cause of amlodipine. So benedipine is the first thing. If you have, when some of the places doesn't have benedipine, you can give cilnidipine. Okay, that is C, calcium channel blocker. D, diuretics, what you can give is that you have indapamide. Okay, you have chlorthalidone mainly, you have commonly what we see. So as a diuretic, thiazide diuretic, you can give indapamide. Okay, that can be given as a diuretic. So first it can be given a combination of A plus C. Can give angiotensin receptor blocker such as our Fimsartan, plus you can give benedipine, A plus C. If not control, you can see next you can add is A plus C plus D. You can add a diuretic along with A plus C. You can add a thiazide diuretic like indapamide. Okay. If not, then resistant hypertension. If it is resistant hypertension, you should add spironolactone. You should add a potassium sparing diuretic along with this. Spironolactone 25 mg should be added. Okay. So you have resistant hypertension here. You have to add spironolactone. So now what happened? What are things you have to look after when you have angiotensin receptor blockers to be given? Okay, you have to see whether the pregnancy is there, contraindications are there, pregnancy, renal artery stenosis, all those things you have to see. If it is there, you cannot give angiotensin receptor blockers. So AC inhibitors is there, but if preferably if these are not there, you can give angiotensin receptor blockers. Now some of the complications are there in this, like you have accelerated hypertension, you have malignant hypertension. If there is accelerated hypertension, you have a new fundus. When you have a fundus examination, new fundus changes are there. And we have accelerated hypertension plus papilledema. It can lead to malignant hypertension. So these many things are there. So if we have something known as hypertension emergency and hypertension urgency. So there is something known as target organ damage. The target organ damage, like hypertension can further lead to complications like heart disease, coronary artery disease, stroke, can affect brain, kidney, renal artery stenosis. Okay, different organs it can affect. Okay, when renal artery stenosis is there, so different organs, target organ damage can happen. So target organ damage, if it is happening, if it is present, that means it is hypertension emergency. Hypertension urgency means there is no target organ damage. Okay, so there are two types of hypertension: emergency, hypertension urgency. So that is also one more thing. That is a emergency condition. Hypertension management has to be there. Okay, so normally what we see is that we have to start with the angiotensin receptor blockers if there are no contraindications. For example, Fimsartan is available, 60 mg to 120 mg is available. Bedtime, if you start, it is good with calcium channel blocker like cilnidipine. If benedipine is there, benedipine is good. If not controlled, you can add diuretics like indapamide. Okay, or chlorthalidone is also given. Okay, so what happens if there is a chronic renal failure with hypertension? So at that moment, first you have to start with A plus C, angiotensin receptor blocker plus calcium channel blocker. Then you have to give add diuretic. Okay, then you have to do loop diuretics has to be given. Loop diuretics. Okay, that is the one thing you give in chronic renal failure. And then if it is again resistant, you can add spironolactone. It can also be given potassium sparing diuretic. But what happens in CAD with hypertension? Beta blocker has definitely to be given. Beta blocker has to be given in a hypertension patient with the CAD. That has to be given. Okay, so beta blocker is the important thing which you cannot neglect in a patient with hypertension as well as CAD. Okay, so that is about the management. There are again many things. As far as I know, I am telling you, there are different class of what we see in our area. We give nifedipine commonly, amlodipine. That are the common things what we see there in our locality. So these many things are available. Latest guidelines are there. Latest type of treatment is there. So ideally you have to control that. You should be aware that your BP should be this much. Okay, you have a control in your BP. So these many things are happening. These many things are there. Then why the beta blocker was avoided? Because beta blocker actually increased the central systolic pressure. The central systolic pressure, it increases central systolic pressure. That's why it was taken from the first line of drug preference. But it has to be given CAD with hypertension. I told you, CAD means coronary artery disease. So those kind of information is there in this management. So that's about hypertension.